Today we're going to go over the radiographic projections and positions of the cervical spine since we went over the anatomy before spring break. The objectives that we're going to cover today are the general procedural guidelines, radiographic procedures, and we're also going to go over the image critique, and there will be a separate video on the trauma procedures and technical factors. So we're going to start first with the general procedural guidelines for the cervical spine, which these are the normal objectives that we go over every class. So it would be the patient preparation, the general patient position, our IR collimated field size, our SID, ID markers, radiation protection, and patient instructions. So starting with the patient preparation for cervical spine, these procedures require removal of artifacts from the anatomy of interest. That would be your earrings, your necklaces, glasses, any type of clothing artifacts, especially if they have a golf shirt on. Sometimes the buttons will show up on their x-rays. And we want to secure all those patient positions in a designated manner and location, because jewelry sometimes can be maybe not expensive, but maybe it has some sort of a memory or something for the patient. So we want to make sure that we don't lose those things whenever we have them remove them for their x-rays. These are some of the topographic landmarks that we may use for our cervical spine x-rays that we went over, that you probably went over last semester with Cheryl. So they are the EAM, which is the external auditory meatus, the mastoid tip, the gonion, okay, the thyroid cartilage, and the top of the shoulders. So these are some of the topographic landmarks that we're going to go over that will help us with positioning for the cervical spine. So our general patient position for these, normally our patients are either ambulatory or non-ambulatory. If they are ambulatory, we can do these upright or recumbent, whichever is easiest for the patient or whichever the technologist prefers to do them. Our non-ambulatory patients, we may have to alter our position to maximize patient comfort, which you'll see some different ways that we have to do them for our trauma projections. And then for our trauma patients, we have to move our IR and central ray to obtain images to maximize patient safety as best as possible. Now our IR collimated film size, we want to use the smallest IR that will demonstrate our anatomy, which usually is a 10 by 12 or an 8 by 10 image receptor if we have those available. And we want to collimate our field size to the anatomy of interest. So usually we have about a 1-inch margin around our anatomy. Some of them may be a little bit smaller, which we'll go over throughout the PowerPoint here. Here, SID, depending upon which projections we do, will depend on what our SID is. So we would use 40 inches SID for our AP axial for the cervical spine, open mouth, our Fuchs, which is also known as the DENS method, and our lateral cervicothoracic, which is also our swimmer's method. Now we would use 60 to 72 inches SID. That's recommended for any projections with an increased OID. So it would be our lateral and our oblique projections. And our markers, of course, we always want to make sure we use our right or left side markers, must be included on each image. We want to avoid using our digital annotation in place of those lead markers, and we want to make sure that our other required ID markers are in there on their final image. So throughout the PowerPoint, we're going to be going over hyperextension and hyperflexion. Those ones we would also need to put a lead marker on for those. It says either flexion and extension or hyperflexion or hyperextension. And then we also want to make sure whenever we do our oblique projections that we always mark the side that touches the image receptor. So which we will get over, which we'll go over those throughout the PowerPoint, and we'll also go over those in lab. Okay, so radiation protection for these. We want to shield our pediatric patients and our patients of reproductive age. Some other radiation protective measures that we would want to do is our close collimation and our optimum technique factors, which we'll also go over at the end of this PowerPoint. Some patient instructions. We want to explain and demonstrate our positions when possible. We especially want to make sure that we're explaining to them what type of breathing instructions they do throughout some of the different projections to make sure that they do them properly. Now, respiration is suspended during most of the cervical spine essential projections. The lateral Grandi technique, we do a suspension after full expiration, and the reason why we do that is to make sure that the shoulders are depressed as much as they can. For our AP open mouth position, we want to make sure that our patient can phonate ah to depress the tongue to the floor of the mouth. That way it helps us get the actual odontoid on our image. In the swimmer's technique, we can use a breathing technique to blur out the lung anatomy for that one also. Okay, so starting with our radiographic procedures, the essential projections of the cervical spine. These are the ones that we'll be going over today. So the AP Fuchs, which is for the DENS, the AP open mouth position for C1 and C2, AP Axial, the lateral, which is also known as the Grandi method, and then the lateral hyperflexion and hyperextension. We're also going to go over our AP axial obliques, which is our RPO and LPO, and then we'll also go over our PA axial obliques, which is the RAO, LAO. Depending upon what your preferences will depend on which one you do. It really doesn't matter, just as long as you, whenever you do your obliques, you do both RPO, LPO, or RAO and LAO. Okay. And then for the cervicothoracic region, we're going to go over the lateral swimmer's technique and our cross-table horizontal beam for the lateral, in case you wouldn't be able to get it erect or supine. Okay, so we're going to start first with our AP DENS, which is the Fuchs. Okay, just make sure you take note that the Fuchs method is contraindicated if you have a cervical fracture or disease is suspected, and only the upper part of the DENS is demonstrated on this projection. So if you would do this DENS projection, you would need to make sure that you also do the AP open mouth also. Now our patient position for this one is supine. The part position is we want to make sure that the chin is extended until the tip is vertical, your chin tip, and then your mid-sagittal plane of the head is perpendicular to our image receptor. Our central ray is perpendicular for this one, and it enters the patient on the mid-sagittal plane, just distal to the chin tip here. Okay, and our collimated field for this one is a 5x5, so it's very small collimation, so you have to try your best to get your lead marker in there if possible. Okay, so our image evaluation for this projection, we want to make sure we have our proper collimation. We want to see our entire DENS. This is our DENS here within the foramen magnum. Make sure you know that. I'm sure there's a question that's going to be on your exam for that. No rotation. We want to be able to see our mandible here, our cranium, and our vertebrae are all symmetric, and then we want to see our soft tissue and bony trabecular detail. The next projection is the AP C1, C2 open mouth, and this is the one that we would do with the DENS. Our patient position for this one is supine or erect, and you'll notice at clinical that some technologists like to do these supine all the time. It's just all on your preference and what you like to do. The part position for this one is you want to align the edge of the upper incisors of your teeth and the mastoid tip to be perpendicular to your image receptor. You want the mouth open as wide as possible. Now your central ray is going to be directed perpendicular to your image receptor, and it's going to enter the patient at the midpoint of the open mouth. Okay, so it just goes right into the mouth that's open there. And I'll actually show you a little trick during lab about how to make sure that it's open properly and that it's all aligned. Our collimated field for this one is a 5x5. This is just another view that you can see, so you can actually see it come through and how it goes to the C1, C2. Okay, our image evaluation for this one is we want to see evidence of proper collimation. We want to see our DENS, atlas and axis articulations between the first and second cervical vertebrae, and we want to entire articular surfaces of the atlas and axis. The reason why we want to be able to see these is to make sure that there's no lateral displacement of anything. We want the mouth open real wide, and we want to see the mandibular rami to be equidistant from the DENS, demonstrating that the head's not rotated. So the trick is to make sure that we get the teeth out of the way, and we also get the base of the skull out of the way so we can see this odontoid process here and the spaces in between. Okay, you either get them sometimes or you don't. Okay, we also want to make sure that we see superimposed occlusal plane of the upper central incisors in the base of the skull, demonstrating proper neck flexion. If the upper incisors are projected over the DENS, the neck is flexed too much towards the chest, and if the base of the skull is projected over the DENS, the neck is extended too much. So we want to make sure that you see the shadow of the tongue not projected over the atlas and the axis also. Now, if a patient has a tongue ring and you have to do this projection, there is a little trick that you can do to move it out of the way. You just have them tuck it off to the side over and then have it move them down. That way it doesn't end up in your image. Okay, the next projection is the AP axial C-spine. Our patient position for this one is upright or supine also. Our part position for this one, our shoulders need to be in the same horizontal plane. That way our patient's not rotated. Our mid-sagittal plane is going to be aligned with the long axis of our image receptor. Our C4 is going to be centered in the middle of our image receptor, and our mid-sagittal plane of the head is going to be perpendicular. We're going to make sure we extend our chin to place the occlusal plane perpendicular to the tabletop. And the reason why we want to make sure we do that is to make sure that the mandible is not in the way of our vertebrae. Our central ray for this one, since it is an axial projection, it's going to be directed through C4 at a 15 to 20 degree angle cephalad. Okay, and then our collimated field for this one is going to be 10 inches long and then 1 inch beyond the skin line on the side. So just kind of like your extremities. So this is our upright here, and then if you would do them supine, you could do it this way. So either way is fine. Now our image evaluation criteria for this one, we want to make sure we have evidence of proper collimation. We want to see the area from the superior portion of C3, okay, all the way down to T2. Okay, and then we want to make sure that the shadows of the mandible and the occipital bone here are superimposed over the atlas and most of the axis. We don't want them down here in C3 and C4, that way we can't see it. We want to see our open intervertebral disc spaces here. And the mid-sagittal plane of the head and neck are going to be perpendicular to the plane of the IR. And the way we're going to be able to tell if they're tilted or rotated is that we're going to see equidistance between our spinous processes here and to the pedicles and align with the midline of the cervical bodies. And then we'll see the mandibular angles and the mastoid process equidistant to the vertebrae. And then our soft tissue and bony trabecular detail. Okay, so this would be a repeatable error here. As you can see, the chin is tucked too far down into their chest area here, because you can see here this is the actual base of the skull here, and then this would be your chin here. So it's down into the vertebrae here into C3, C4, so you aren't able to see them properly. So you would need to repeat that and have them bring their chin up. Okay, the next essential projection is the lateral C-spine, which is the grande. The lateral projection demonstrates the zygapophyseal joints of the cervical spine, so just make sure you keep that in mind. That's very important, that the lateral C-spine projection demonstrates the zygapophyseal joints. Okay, the patient position for this one, we want our patient to be upright, seated, or standing. Our part position for this one, our mid-coronal plane now is going to be perpendicular to the image receptor, and our mid-sagittal plane is going to be parallel to the image receptor. We want our C4 to be in the center of our image receptor, our shoulders in the same horizontal plane, but we want them relaxed down. And whenever you do this position, you can actually have your patients have sandbags in their hands also to depress those shoulders down if you need to. The chin needs to be elevated and the mandible needs to be protruded out, so then it's not overlapping any vertebrae. And our central ray for this one is just horizontal and perpendicular to C4. Our collimated field for this one is 8 by 10. Now for our image evaluation for the lateral C-spine, we want to see again evidence of proper collimation. We want to see all 7 cervical vertebrae and at least 1/3 of T1. If we don't get that on our image receptor and on our image, we need to do another image, and usually that's one whenever we do what's known as a swimmers, which is the cervicothoracic region. We want to make sure that our C4 is in the center of the radiograph and our neck extending so that the mandibular rami are not overlapping the atlas or the axis. See how this is up in front of this instead of in actual C1, C2. So you're going to make sure it's out and not in. Okay. Now also for this one, to be able to tell that there's no rotation or tilt on the cervical spine, we want to make sure that we see superimposed zygapophyseal joints. Now you may see on some things that they're called apophyseal joints. It's the same exact thing as a zygapophyseal joint. And we also want open intervertebral disc space. Okay, we want superimposed or nearly superimposed rami of the mandibles. That would be up in here. We want that to be superimposed. If we would see any type of bone on the other side here from the other side of the mandible, that means that the patient's head is rotated. And then our spinous processes here should be shown in profile. Okay. So as you can see in this image here, we see 1, 2, 3, 4, 5, 6, 7, and then we see the third of T1 here. So that's an acceptable image. So this lateral C-spine image here would be a repeatable image. As you can see, there's a bunch of artifacts on here. These here are some earrings, and this here would be a necklace. These earrings are right in C1 there, so if there was a fracture, you wouldn't be able to see it. And as you can also see, if you account these, 1, 2, 3, 4, 5, 6, C7 is covered, so we can't even see C7, and we also need a third of T1. So we would need to repeat that and depress the shoulders. So you can see in this good image here, we can see all of the vertebrae here, including T1, because the shoulders are down and depressed, the mandibles out of the way, and the spinous processes are all in profile. So that is a good image. Now, sometimes if a patient is unable to stand, maybe they come down on a stretcher down to the department. This one also follows through with a trauma C-spine, which we'll go over in the next video. But we'll just use this one as if a patient would come down on a stretcher. Maybe they aren't able to stand and it's really hard for them to get over onto the x-ray table. You can perform this first. Say they come in, maybe they had a fall at home. You don't want to roll them up on their side. Maybe they have a fractured hip. You would want to do this one first before you would do an AP, axial, or an open mouth. So you would do your lateral first, have your doctor, physician check it, and then you would continue on with the rest of your images. So your patient position for this one would be a dorsal decubitus position. You again want to make sure that the shoulders are relaxed. So you would have them, I always tell them to reach down towards their toes whenever I do this position. That way they pull their shoulders down as much as they can. You want the head without rotation. You want to ask the patient to look straight forward without moving the head or the neck. You want to put your image receptor vertical, and you want to place the top of it at the shoulder in an actual grid holder like we have in the lab. Our central ray for this one is horizontal, and it's the same central ray as you would for your lateral grande. It's just centered to the midpoint of the image receptor, which is C4. Our image evaluation criteria for this one is also the same as the lateral position of the grande, and it's the entire cervical spine. We want to see from the sella turcica, which would be here, to the top of T1. The entire cervical spine in profile with minimal rotation and distortion, and we want our proper collimation. Now, if we aren't able to get this, we would do what's known as the swimmer's position, which we'll go over next. And that's what this says here. So if the top of T1 is not demonstrated, the lateral cervicothoracic is required to do to make sure that the patient is completely cleared. If you still do not get a good image on the cervicothoracic, they usually send them over for a CAT scan. So this will be an example here of not a good one. So you can see 1, 2, 3, 4, 5, 6, and you can barely see 7 here, and then this would be the spinous process, and you can't see T1, so that would have to be repeated, or you could do a swimmer's. Which this is a swimmer's here, which is the lateral cervicothoracic, and the reason why we call it a swimmer's is because the patient looks like they're swimming whenever they do this position. The patient position for this one, you can do it upright, seated, or standing in true lateral position. Recumbent true lateral position, and you can put a little support underneath their head, or you can have them put their arm underneath there to help them rest their head. Now, part position for whenever they're standing, we want the mid-coronal plane center to the midline of the grid. We want to extend the arm that is closest to the image receptor above the head, and then we want to rotate the humeral head anteriorly. That way it's not in their actual cervical vertebrae. If upright, you can flex the elbow and rest the forearm on the head, so it's more comfortable for the patient. We want to depress that shoulder down further from the IR if possible, and the head and body in true lateral position, and the C7-T1 interspace is in the center of our image receptor. Our central ray for this one is going to be perpendicular to C7-T1 interspace if the shoulder away from the IR is depressed. If the shoulder can't be depressed enough, you want to angle your your central ray 3 to 5 degrees caudad. Then our collimated field for that one would be a 10 by 12. Most patients you will need to angle the tube though for this position because they're not able to depress the shoulder down enough. Our image evaluation criteria for the swimmer's position would be evidence of proper collimation. We want to have adequate x-ray penetration through the shoulder region, demonstrating the lower cervical and upper thoracic. No rotation from the lateral position, and we want our humeral head minimally superimposed on the vertebral column and soft tissue and bony trabecular detail. So your humerus is over here, so you can't really see it too much over the actual vertebrae on this one. A little trick that you can use to make sure that you have it properly positioned is you can look for the wishbone with the clavicles. See, here's one here, and then this one here. So that would be your wishbone on your image, and that would be a good image there. It's just a little trick. Now the next two that we're going to go over is the lateral C-spine hyperflexion and extension. Now these, you have to rule out a fracture or any type of pathology before you would attempt to do these positions, because then you could cause more of an injury to the patient if you didn't do that. So these are actually used usually to demonstrate an absence of normal movement from trauma or disease. So they would do these mainly before like surgery or something like that, to just be able to see what they're looking at if they have a torn ligament or something like that. So our patient position for these, you can do them uprighted, seated, or standing. They usually like them to be upright though. And the reason is to just make sure that you're actually seeing the movement done properly and to make sure that everything's okay in there. But your apart position for these are going to be the same as for a lateral grandie. And then for the hyperextension, you're going to have the patient relax the head back as far as possible. So that would be in this picture here. And then we have our hyperflexion, have the patient put the chin as close to the chest as possible. Our central ray for these are horizontal and perpendicular to C4, the same as for the lateral grandie. Our collimated field is 10 by 12. Now these are usually done in a series where they would do the lateral and then they would do hyperflexion and hyperextension, and these are the ones we would make sure that we mark with the lead marker on our image receptor also, or our board, with flexion and extension. And then you would also do neutral if you would do just the lateral. Now our evaluation criteria for these, again, we want evidence of proper collimation. We want all 7 cervical vertebrae in true lateral position. We want no rotation or tilt of the cervical spine. We want superimposed zygapophyseal joints and open intervertebral disc spaces. We want superimposed or nearly superimposed rami of the mandible. And we want our spinous processes shown in profile, as you can see here. Now, depending upon which one you do with the hyperflexion or the hyperextension will depend on what we want to see best in them. So we'll start first with hyperflexion. So we want the body of the mandible almost vertical if it's normal. We want to see all 7 spinous processes in profile elevated and widely separated. Okay, so we don't want to see them together. Whereas hyperextension, we want to see the body of the mandible almost horizontal if normal, and then we want to see all 7 spinous processes in profile depressed and then closely spaced. See how they're all depressed together, whereas these ones are open. Okay, so that's our flexion and extension. And remember, we only want to do these if they are cleared for injury first. Moving into our oblique projections, we'll do AP axial first. Now on these ones, the intervertebral foramina is going to be on the side furthest from the IR, are going to be demonstrated. And we do both sides, like we said before, examined for comparison. So the intervertebral foramina on the side furthest from the image receptor are going to be demonstrated on these projections. Our patient position for the first AP axial, we're going to be upright, seated, or standing, and we want to put them in a 45-degree oblique position. Okay. If you do them recumbent, it'll also be a 45-degree oblique position. Now our part position, our head and body, are going to be at a 45-degree angle from the image receptor, and our C-spine is going to be centered to our image receptor. And our IR is going to be centered to C3. Okay, and we want our chin elevated and protruded out. Okay, I usually have them, I'll go over that with the PA, but usually whenever I do them PA, I have them look up into the corner. That way, you know the chin's up and elevated out. Our central ray for this one for AP is directed to C4 at a 15 to 20 degrees cephalad, and our collimated field for this one is also an 8 by 10. Okay, so our AP axial oblique C-spine is going to have the same angle as our AP axial C-spine. Now our image evaluation criteria for these, we want to see again evidence of proper collimation, all 7 cervical in the first thoracic vertebrae. We want to be able to see an appropriate 45-degree rotation of the body and the neck. And the way we want to that we know that we will have that is if we see open intervertebral foramina. Furthest from the IR from C2 to C3 and then to C7 to T1. Okay. Now, we also want to make sure that the chin is elevated appropriately. That way they're not having overlap over C1 and C2. And how we're going to be able to see that is that the mandible is not going to be overlapping the atlas and the axis, and then the occipital bone is not going to be overlapping it either. Okay, so the occipital bone and the mandible. We want to make sure we have open intervertebral disc spaces for this one, and that is what we primarily want to see on this one. Those are the best demonstrated structures, and then our soft tissue and bony trabecular detail. So these would be both for your AP axial oblique C-spine. This would be your LPO, and this would be your RPO. So we want to make sure whenever we put our markers on, see how the shoulder is touching the image receptor, we put a right on it. The left shoulder is touching the image receptor for this one, so we put a left on it. So whichever side touches, that's the marker that we put on for our obliques. Moving on to our PA axial oblique C-spines. The intervertebral foramina for these ones, the side closest to the image receptor, are demonstrated, and both sides are examined for comparison, just as the same as the AP axial. So for this one, for our patient position, again, we can do these upright, seated, or standing in a 45-degree position. Recumbent, again, 45-degree position, obliques. Our part position for this one is head and body at a 45-degree angle to the IR. Our C-spine, again, is going to be centered to our image receptor, and our IR is going to be at the level of C5 for this one because of the angle that we have to put on for it. The chin is elevated and protruded, the same as with our AP axial. So you can see that she has her chin elevated and protruded up. Now our central ray for this one is going to be directed to C4 at a 15 to 20 degrees caudad. Now our AP axial was cephalad. Our PA axial is caudad, and our collimated field for these ones is an 8 by 10. Our image evaluation criteria for this one, again, evidence of proper collimation, all 7 cervical in the first thoracic vertebrae. We want our appropriate 45-degree rotation of the body and the neck. We want open intervertebral foramina that's closest from the IR from C2 to C3 to C7 to T1. Uniform size and contour of the foramina. So again, we want to be able to see those intervertebral foramina in here, and those are the holes. Okay, and then we want to see appropriately elevated chin. So again, we don't want the mandible overlapping the atlas and the axis or the occipital bone. And then we want our open intervertebral disc spaces for here. Okay. And these would be our PA obliques, but just keep in mind the PA obliques have the marker placed PA on the IR and the side touching the IR, and the images need to be flipped whenever you do them PA horizontally, so they're viewed in anatomical position. So if you would take this PA oblique and you would put the left marker on here, if you wouldn't flip it, the left would actually be over here. So you always want to make sure you flip it, that way they don't think that you marked the wrong side. So just keep that in mind if you do them PA. So this would be the example here. This would be your image prior to horizontal flipping. Notice the positioning is PA oblique and the side marker is PA. And then after you flip it, it looks reversed. So just make sure you flip them to make sure that they know which side is which. And this is the end of the first video. The next video that I will be doing will be going over trauma images and also the technical factors.